we'll start our last roundtable discussion. What if we really regionalize the healthcare system with Xavier Bertrand, Alain Berthéas, Michel Lafourcade, Olivier Véran, and the debate will be moderated by Olivier Mariotte. In any case, I'll hand the floor to Xavier Bertrand immediately so that he can talk to us about what the regions can provide to healthcare and the way you see this as the president of a large region, les Hauts-de-France. I'm not trying as a president of a region to continue the action that was myself as mine as the Minister of Health. I'm aware today that the role of the state or the political administrative system at the national level is not working the way it should be. And in the territories and in a large region, that's where we can be pragmatic but also effective. But be careful. I'm not saying that we need less state. And had I participated in the previous roundtable discussion, I heard the end of it, I would have expressed myself saying citizen companies, yes, but the state always has a role to play. Maybe we could define the welfare state, but the state counts in terms of ethics, and no one can take this on in terms of private interests. But I think that we need to fully revisit the place of the state and the local actors, and particularly the regions, and we can start the debate talking about the role of the regional healthcare agencies. For the Hauts-de-France, it's clear that we can't satisfy health indicators that mean that life expectancy is 2 years below the national life expectancy. In my region, if I'm not the state, if I don't have a mandatory competency, I want to contractualize it with the state to try to set up innovative policies in terms of demographics, in terms of assistance to the establishments. I think of at the healthcare centers, we're going to double them. Also the public and private establishments for equipment, for facilities. I think that in terms of prevention, it's high time that we started to have a more operational way of working and not limiting ourselves to just discourse. And I also believe that there are strategic sectors. I think of neurodegenerative diseases. And we're going to have to focus on this. So the question of people, staff, the question of the establishments, the question of the strategic sectors to be developed. I think a region is perfectly legitimate in acting on these topics, and the budget that we have in my region, 5 million euros for investment in health, 5 million for the operation. I don't have the precise figures yet. I'll know them at the end of the year in our budget commitments, but we will increase this budget even beyond our real competencies, because I can't support the fact that my region has poor health indicators. Thank you, Xavier Bertrand, for this introduction. I think you've set the stage for the debate. I had prepared a text on this topic. As opposed to the previous roundtable, we talked about Jacobian attitude and decentralization, but this time we're really going to focus on the regions. I thank you, Guy, for having accepted the title that I proposed, talking about should we be giving Paris its independence? That's what the French title is. Paris invented independence. They also invented the pain au chocolat and Alain Delon and many other things. So Paris is the world, if you like. And if Paris is the world, the question is, how will we get away from this way of thinking, this Parisian way of thinking, to see how in the regions we can have another type of management and ensure that we can create something that's living, efficient, and based on a bottom-up strategy. And I'd like to hand the floor immediately to Alain Berthéas to talk about the way, Alain, you're living this dependence between Paris and the functioning of the regions, this relationship. It's always difficult to speak first and to answer this type of question. I'm not sure I'm going to be making any friends, but I'll proceed nevertheless. We're not here to make friends, but I'm still going to be careful about how I say this. When we talk about Paris, are we talking about a city? Or are we talking about the seat of the French government? And in general, when we're in the in the provinces, when we say, I'm going up to Paris, that's generally what people say. And we go and listen to the message that comes down. We're going to listen to the thinkers that are going to tell us what we should be doing. And then we go back into our regions. We try to apply what we've heard. And to be completely frank, I don't like the situation at all. It all depends on if I go up to Paris wearing my hat as an industrialist or if I go up to Paris wearing my hat as the local elected official. In one case like the other, I always have the feeling that I'm going to see people who are going to tell me, we're going to explain what you have to do and how you can do it, and I never hear, what would you like to do? And that's a real difference. And I think Xavier Bertrand said, there are possibilities in the regions and in the territories. The current French organization forgets about the reality of the territories, of the regions. We always say we're a country of 25,000 municipalities, 36,000 municipalities, 25,000 with less than 2,000 inhabitants. So it's widely dispersed. It's ridiculous. There are too many elected officials, but it's a reality. And this reality, instead of trying to work with it and develop it, we're denying it. And that's the difference that we have now between this famous Notre law. It's the new territorial organization of the Republic. It has a real ambition. And in the end, it achieved nothing. We have 13 regions instead of 24 at the beginning. We gave a little bit more responsibility to the territorial authorities, like the groupings of municipalities, the intermunicipal organizations. So there's a problem between the nation state and the welfare state. The high responsibilities of the government, the regalian responsibilities, are not being managed anymore, and it's the regions that are having to deal with this. The competencies have to be clearly explained. We hear a lot about the millefeuille, the many-layered cake in France, and I think we have to start with defining who does what. It would be clearer, rather than having this mix where everyone can do something, but in the end, when everyone does something, no one does anything. Thank you very much for that message, and I think it really reflects what 64 million French citizens believe around Paris. I'd like to turn to Michel Lafourcade. When we prepared the round table, he said he was a Jacobin from the Gironde region. So Michel, do you think that when we look at how things are broken down between Paris and the regions, do you think that there's that Paris understands the regions and looks at them with a benevolent eye? I think that the task is difficult given what I'm hearing, what I've been hearing since this morning about the regional health centers, but I'm going to try to stand out a bit in my message, and maybe I'll disappoint some people because I've understood that there's a general appetite to call for decentralization or the more full deconcentration.
So when we propose a reform, in other words, a solution, it's to respond to certain problems that have been clearly identified. Now, what about the diagnosis? We've been hearing about the diagnosis for the last 2 days. The diagnosis has been delivered. I've also heard people promising the apocalypse for our healthcare system. I don't think we are facing an apocalypse, but most of the time I've heard about centers of excellence, especially for healthcare. The World Health Organization says that we have a great healthcare system, so let's not forget about that reality. And I've also heard that there are shortages, gaps, and there's the question of prevention. the ability to network for managing healthcare pathways. Then there's the equality of different regions. We've heard that from Mr. Bertrand. So these diagnoses of all of these problems, well, I don't think that they are worth complete decentralization, anything radical like that. Anyway, I don't know how these two solutions would allow us to respond to these problems. I'm only going to give you one example before going into others over the course of the discussion. The question of restructuring. It was notably a question of restructuring yesterday morning. People wanted forced restructuring. I don't think if we can go faster with any kind of restructuring. What I can say is that restructuring is complex between what Paris wants and what is real in the field. And it seems to me that for restructuring, we shouldn't be embarrassed. Let me just give you an example. The question of maternity. Two figures. In 1975, over 1,300 maternities wards were in France. This figure has gone down to 500. So there's been a revolution in favor of safety, a revolution that the population has speeded up. This revolution emerged not for financial reasons, because when you close a maternity ward, it's usually a level 1 ward. Women go and give birth in another maternity ward, which is a level 3 maternity ward. So it's going to be more costly for the national health insurance. But what about the silent restructuring? We're seeing this. I don't see how we can have proposals that are suggested in your title, how we can have more decentralization, how that would help us go faster or more intelligently in this approach. Olivier Mariotte, you're from the Dauphiné region, you're a Jacobin. What do you think of this organic link between Paris and the regions, and in particular, the very concrete aspects, healthcare pathways? Can we think of a regional numerous clauses? Is that a bad word? Without any national coordination, a region handling its own affairs. Well, thank you. Just to come back to what Michel Lafourcade said, in the hospital sector, we've got rid of 40,000 beds. We've done this silently. We've done it over the course of 10 years. So 15,000 beds axed in surgery. So that's 2/3 of the activity of the University Hospital in Tours. And so the elected officials have disputed this. People in Parliament say we need to get rid of small structures. They wave the flag, and then people are up in arms against maternity ward closings. We hear elected officials talking about maternity wards, specific cases. Hospitals are the first employers in regions, and that's something we forget about. They are there to support the economy of the regions. So let's come back to what Xavier Bertrand said. It's clear that there is, in areas, in regions, they want to invest in healthcare. On paper, we've got rid of the general authority clause. Normally in municipalities and regions and in départements, we don't necessarily want to invest in healthcare, but the elected officials are aware that it's a good subject from a political point of view. It's one of the services that the French people are attached to, so they try and follow it. I've followed a number of municipal campaigns. All municipalities, in their campaign promises, wanted to develop multidisciplinary health centers. There's not one program that didn't promise to multiply by factors of 1, 2, or 3 help for development of health centers. Now, the figures are impressive. We invest 180 million. We invest 180 million for the medical field. So we've got to be careful. We're not talking about proportions that allow us to have major action. So in terms of decentralization towards local authorities, in terms of healthcare investment, we are really at the embryonic stages. Now, would I agree to move ahead towards the investment of local authorities? What can I say? In terms of prevention, Xavier Bertrand reminds us of this, and he is right to do so. There are areas where the public health objectives are not the same as elsewhere. Hauts-de-France, Rhône-Alpes-Auvergne, and even at intra-regional levels, the priorities are different. So for prevention, I think there is a challenge. Investment, first of all. Regions are investing in multidisciplinary health centers and other centers, and some local authorities have even forked out thousands of euros in order to renovate places. This is what happened in the PACA area. Aix-en-Provence did not do this. If it hadn't done this, the hospital base would not have been renovated. The question is, should we be going further? Should we make it possible to manage risks? Should elected officials and local authorities have to manage risks? I don't think that this is their role. Let me give you an example, and then I will stop. The German example, you have the landers who can invest and who have the responsibility of the hospital buildings themselves, like the regions are responsible for schools in France. In Germany, you've got the highest rate of hospital beds per population. So I think we've got to develop prevention, public health care. We've got to allow investment in digital technology. The regions have made this possible. This is something that's done in collaboration with the regional health authorities. I think we've got to push for innovation in regions. But healthcare organization has to be based on the state and a decentralized state where we have regional health authorities. Let me hand over straight away to Alain, who's going to react to what you've said. There's something that we need to talk about in this debate, and that is the ODAM question. So, in respect to what's been said, I fully agree with that point of view. I've been a local official for a certain number of years now, and we're seeing a certain number of difficulties, real difficulties in different regions. Regionalization should allow us to meet a number of problems in terms of support, not necessarily, as has just been said, in terms of responsibility. One example for municipal organizations, grouped municipal organizations, so 45 municipalities grouped to one, what we refer to as urban and rural organizations. We worked with the regional health agency in the Rhône-Alpes area. Now it's Rhône-Alpes and Auvergne. So we are from the Forez area, and we're between the two regions, in fact. And in fact, we had a Forez side, a Rhône-Alpes Forez side, and an Auvergne Forez side. That's no longer possible now with the new regions. So it's a big region. I'm very happy with that big region. One thing, we worked on a local health plan. And the objective of a local health plan for a grouping of municipalities, not to take over the responsibility of the healthcare pathway, and it's not to focus on the healthcare pathway either. But we forget that this is a healthcare pathway. And when we talk about medical deserts, why are the elected officials so stressed about this? Well, quite simply, because today there is a tendency to put patients at the center of the debate. But in regions, we've also got to think about citizens. They have to be at the center of the debate. So are we talking about citizens or patients? So this is how we can act. And where the difficulty lies is how we draw up a local health plan. You start with one term of office, but you finish with another term of office. The number of discussions, and it's terrible. And all of this regulation is terrible. noted a certain number of interesting words in the previous debate: trust, coordination, control. We're mixing it all up. We're mixing up coordination with control. We want to be strategists, but we want to be operatives as well. And it takes an awful lot of time. And that's where centralization is very dangerous. Because we want to deal with everything and anything, we're not dealing with anything properly. So we're no longer talking about patients or citizens, but files. And that's terrible. So, Michel Lefourcade, there's something that I would like to hear about from you. When you're an elected official, because I'm also an elected official in a village, the question of health takes up anything that is to do with medical or social affairs. We're confronted with situations that are mixed up, that are contrasting. And there we have a big problem as officials. You've got the healthcare system that depends on national systems, and then you've got the medical and social organizations that depend on the county. So what kind of solutions can we use? Because elected officials are often faced with this kind of problem. Who are the right contacts for dealing with this? I think we really need a one-stop office to look at healthcare pathways. I think that is a very important question. It seems that our natural appetite to reform governance must really be questioned. Is it a question of, I think it's a question of being more proactive. We need to change policies. I think at least we need to invest as much energy in this change, because usually we have constant governance, we usually have constant regulation, and there's this habit of partnerships. So we've talked about possible partnerships several times between different local authorities, the regional authority, and then other authorities. Closer to the field, this is what we should improve on. So just to respond to your question more specifically, about the medical and social organizations that are under the county authority, and healthcare, which is under the authority of the regional authority, we must make sure that the gap is filled in every day. And it's quite possible to do this, of course. So we've been hearing about the healthcare pathways. We want to avoid hospitalization, but on condition that the conditions for home care are improved. This is a policy that we can implement together out there in the field with a county council. This seems to be the heart of the problem, but also that of the solution. Xavier Bertrand, are you still with us? I'd like to ask you the same question. How do you see this link closer to counties, local areas, these three worlds that are complementary but don't really rub shoulders with each other? So the three worlds, so the healthcare world, the medico-social world, and the social world. Well, we can't really think as if the current territorial organization is going to last for 1 century. Everybody has understood that there's a real problem in terms of the future of départements or counties. Everybody knows today that because of the budgetary constraints, in 10 years' time, we might have the same debate, but I don't know whether we'll be doing this on a county level. So if it's to think for the next 10 years to come, it doesn't offer the same interest. Now, I don't agree with Mr. Lefourcade. We can't say that we're going to continue our health system like this. Why talk about disasters? Our system has been considered the best in the world, but it is in danger. From an organizational point of view, it needs to be changed deeply. Our system is not following these changes, and so there's a problem. There's the problem of financial, economic, and budgetary resources. We can't pretend that everything is going well when there are shortages. It's not because the figures improve 1 year that everything is going to go well in the future. We've really got to look at the allocation of the resources. There are not enough resources for healthcare. And we can't continue to change with all of these shortages. It doesn't work. It hasn't worked in the past, and it won't work in the future. So we wanted to talk about this with Guy. But when you look at the political programs, after 2 debates, a presidential debate where we never talked about healthcare, I think we're going to have the question of health evacuated once again, or the additional health insurance will be paying. These are the political programs, even those of my own political family. Let me just move on to a last point with Mr. Leforcade. When he says that the current decentralization system is okay, it's not additional decentralization that's going to make the difference. I want to have a point of contact in my region. Jean-Yves Rad, I'd work with him. He has a form of autonomy which has its limits. Generally, in relation to all of the funds for health in the region, what is your room for maneuver? What is my room for maneuvers? How can we have more room for maneuver if you are directors of regional health agencies? There is the Regional Intervention Fund, and it is a great invention that makes it possible, that allows for fungibility. So in absolute values, I can use as much money as I want, but that's in absolute values. But it's speculatively. I can give it to public health, but the reality, of course, is that we cannot do this concretely. We can only use modest proportions, and I will just talk about 2016. This fungibility is being transferred, and it will be something like 3 or 4 million. So we have progress to be made in this area, most definitely. Let me just insist on this point. As the Minister of Health, what did I do? Well, there was enormous pressure placed on general managers to improve the healthcare figures and to make sure that they were okay. Now, when you don't invest in additional resources, a general manager of an agency has to manage shortages. But because there is pressure from above, they have to then pass this down onto other managers, and that's the way the system works. And that's why we can't just talk about this. We have this priority. When I talk with the general manager of the agency and talk about a new healthcare project in the region, I try and see with him how we can do it in a coordinated manner without walking on each other's feet, how we can invest resources properly. So, and we need that dialogue. Olivier, what would you say about all of this? Yes, I agree with what's been said by Xavier Bertrand. The Regional Intervention Fund, it's 3 billion euros. There are so many priorities to be financed for this fund that there isn't even a margin of 10% to finance something else. And the worst of all of that, the thing that I find the most frustrating, is that you're going to be financing experiments that will work well the first year, the second year, the third year, but as it's temporary money, it's only a temporary investment. The experiment collapses. And on top of that, what about the national cost of experiments in local areas? It means that we can't use innovation, use professionals in initiatives at national levels. So if we talk about decentralization and regional authorities, I'm for the fund. So the idea is to reinforce regional health authorities, have more human resources, but we've already got these big cruise liners, but we don't want to have something too big, otherwise we won't be able to govern it. So we have to be very careful about these points. And just to talk about the ARS, the authorities again, the regional health authorities, I think we've got to look at the assessment and trust the assessment. Instead of having a manager who has to go up to the ministers because there are local pressures, instead of having to go up to see the health minister and complain about plans to close establishments, I think they should have a 5-year term of office. In other words, we trust the general manager. We give not all powers to this person. We give them independence in terms of elected officials, and then we talk about it after assessing it. But perhaps give them a little bit more autonomy from this point of view. But the big question is about giving financial room for maneuver to the regional health authorities and to the stakeholders to do what? How do we organize this? We need to work on setting up healthcare pathways. There's the financing mission. When we look at each other and we're desperate, we look at what's happening abroad. We look at integrated healthcare pathways for chronic diseases. We look at experiments that are working in local areas. There are different models. We haven't yet found the right solution. There are countries that develop decentralization and have healthcare producers. There are local healthcare networks, primary care trusts, where you have doctors, sets of doctors who allocate envelopes and who pay specialized care in their practices, and that pays for part of the medical and social proportions. You've got decentralization for integrated care, and this comes back to what we were saying, complete integration of medication and medical and social affairs. This is something that's happening in Quebec, and then you have the authorities, regional authorities, but also local authorities. This is the case in Germany. Sometimes there are decentralization towards privatized models, care networks, private consortiums that have budgets and that are in charge of paying healthcare with hospital stages. Notably, this is what we can see in the United States. It hasn't been assessed yet. I refuse the idea that we are not able to modernize and to have decentralization that is more effective in France. Article 74 of the health law supports this. It talks about support platforms. That's a form of decentralization for some kind of administrative authority. What are these platforms? Well, it's the bringing together of private people, hospital people in local areas. It's field initiatives that are financed by the regional health authority in order to improve the congruence, to break down the silos, and to finance healthcare pathways. The first assessments, I was talking with the general manager of Bordeaux, Mr. Bigourou, I don't know if he's still in the room, and he was talking about some very good things. He was talking about what's happening in the lands in terms of territorial. It's something that's new, so we have to, we can't be immobile. We have to move towards more decentralization.
Yes, when we talk about these support platforms, private doctors are not really involved in building all of this. And so we're faced with another regional cruise ship, which is a huge machine, which these are the GHPTs. These are public hospital groups in the territory. So with respect to this construction, I think we have a real firing power and a real citadel within the region that's created by these, and which apparently, according to private practice doctors, will not encourage dialogue and permeability of the structures in the territory. How can we, at the regional level, ensure... Could I just add something? Just a second. Here you're really touching upon a very important point. Whatever the government, it's a real issue. If you're in a very state-based approach at the government, there is a public prism. I'm not saying that in the regions you have the way to counterbalance this, but you do have elected officials who are pragmatic, because even beyond their political philosophy, they're more in favor of this coordinated healthcare circuit. So I know people don't all agree with me here, but this is my conviction. The way you can balance this is really decentralization in a certain sense. Okay, we agree then. Oh, I didn't ask you necessarily to agree with me, but Michel, what would you say? The rebalancing of power between private practice and public. Is the ARS the guarantor? Yes, I would answer yes without hesitating. I don't want us... we don't always succeed systematically, but that's the example of the PTAs that you just mentioned. Is for me a superb example, both of something that is possibly, finally, modelizing a form of local healthcare system of tomorrow, of the future. Why is it so interesting? Well, because these PTAs are designed for patients, for users themselves, especially those who have a complex healthcare circuit. That's about 15 million patients in our country that have chronic disease, for example. They can then concretely address professionals within this platform who will then guarantee a form of coordination in this pathway, which is so complex for them. And it's also an entry point for all private practice. In other words, a private practice doctor who wants to accompany the elderly person over 75 who has Alzheimer, for example, the private doctor cannot spend 3 or 4 hours looking for a place in a retirement home or a special Alzheimer's home for this patient. So this platform, he will be able to contact this platform. And under his authority in the professional and scientific sense of the term, this platform will be able to replace him to help him in this absolutely indispensable circuit. And I would like to say that it's finally something that existed previously. There was the PERP system for the elderly, but it's a way to really ensure this pivotal role of the GP, the family doctor. He wanted to do it, but he didn't have the availability and the means to do it. So I think now we have a shared responsibility, obviously, to ensure that for the entire territory, this type of platform could be installed and in a homogeneous fashion. Yes, I'd like to come back just to what Olivier Véran said. Not all elected officials are idiots who spend their time crying local officials. Believe you me, we're not always saying, oh, Madam Minister, please look how mean they are at the ARS, at the Regional Health Agency. Luckily, we also try to have to work on construction and logical construction in the medium and long term. One thing that I think is important to highlight, and that we've heard yesterday from almost everyone, people are talking a lot about the healthcare, the coordinated healthcare circuit. And we're actually quite good in France in those terms, in terms of this coordinated healthcare circuit. However, we still have one difficulty that Xavier Bertrand underlined, is we have to manage the shortages. We have a problem of the quality of what we want to produce with the cost that it requires of us. So often we have an economic approach that's very short term, an accounting approach. We manage the shortage. And I think the difficulty that we find ourselves in now is to be able to really set up a long-term vision. Accounting just observes the damages, if you will. You always have one column for your income and the other for your expenditures. And people always say, ooh, you're spending too much, so you have to tighten the screws. If we have a long-term vision with this famous fungibility of the budgets, the departitioning, the fact that in a sense we're trying to think about a whole process and no longer in these silos side by side, we must be able to construct in a country such as ours that still has resources, although in a certain number of areas we seem to be getting to the bottom of the barrel, but we do have a capacity, I think, to do this. And I think we all should be reflecting on this. And Mr. General Manager of the ARS, we have to really set up a real dialogue in the territory. I would just like to make this small comment with respect to my experience locally in healthcare, that we succeeded in signing an agreement after 7 years, but it was a tough process. Once the agreement is already signed, or the objective is signed, it's already obsolete after 7 years, so we have to reassess it. But to do this, we have to have a real dialogue. The huge difficulty that we find ourselves in today is that we simply have rules, these very rigid frameworks within which we're discussing things. And these frameworks are totally anti-economic in terms of corporate economics or business economics, and they're also anti-creativity. So I think that this is where we have a real difficulty, where the question is not, do we centralize or decentralize? And as Nicolas Bavras just said, the question is rather, what solution for what need? If we're able to discuss the needs, we will observe that from one territory to another, within the same region, depending on the geographic and demographic realities, there are differences. If we can't take them into account, I'm sorry, then we'll continue to manage shortages because we won't be able to meet real needs. and we'll do what Xavier Bertrand was saying. We'll invest in sand. We'll just be watering the sand, and we'll say, oh, it's not growing. That's really surprising. Olivier, I'd like to hear from you. And then let's talk about telemedicine. I think magnificent things are happening with telemedicine. But first, Olivier, could you react to what Alain just said? And then, if you talk about telemedicine, to me, it really hurts me to see the lack of enthusiasm of the public authorities. The regions too have a role to play in the financing of the digital plan in the hospital. I think it's 2 billion euros if we equip all public healthcare establishments with innovating digital systems. And here, I think the regions really have a role to play. Now, to go back to this notion of territory, just a little story about medical demography. In the 90s, people didn't talk about shortage. People said there was a surplus, a medical surplus. People kept talking about this. And the first regional observatories, they were organized in this period of surplus. They said, what are we going to do to prevent doctors from setting up in certain territories in 2002? And this was a real bomb, because all of a sudden, someone said, no, now we have a shortage. If you look at the occurrence of the word medical desert in Google, it only appeared once in 2003. So we went very rapidly from a huge surplus to a shortage, because we didn't have this territorial approach to analyze needs. Some people are recommending this selective application for doctors to set up in certain areas. My question is, how do we evaluate in the territory? We should be able to call each GP and say, are you working full-time or part-time? Do you have a specific discipline, or are you a general? How long do you think you're going to continue to practice? 5 years, 10 years? What's your waiting list like? I don't know what the healthcare need is if we don't have this type of survey. And we have some very detailed surveys that only talk about consumption of care and the number of doctor's visits per inhabitant. I don't know whether 4 visits per year per inhabitant is good or not good. So we need to be closer to the territory, and I think there's an app that could be an application with a linkage to local organizations in the territory. I totally agree with you. This vision, this territorial vision, are any analyses of this type carried out? Any surveys in the regional health agencies? Do you do this, or would this require resources that you don't have? In terms of needs analysis, indeed, that is the most important question, I think, in healthcare and social issues. I think we have made progress in recent years. We can now, in a very territorialized way, we can combine our analyses, but we can look at what the health insurance is telling us and what the regional observatories are telling us and what the universities are telling us. But it is an eternal struggle, and we've never won the struggle, but we need to continue. We never should confuse the need with the demand in our sector. It's not because the demand is expressed that there's necessarily a need, and it's not because a need is not led to a demand that it's not fundamental and vital. So we're trying, but we have a real margin to improve here. And if we talk about telemedicine, typically this is something that I think is really an absolutely fundamental action that we should commit to with more strength and more enthusiasm. I totally agree with what you said. I don't want to seem to be asking for an additional funding, but I would need some elements in terms of pricing, telemedicine pricing, that would help us. But nevertheless, concretely, all of this is gradually being implemented in the territory. I took the last example of telethrombosis, or which is a good way of dealing with strokes. We cannot have a neurovascular unit in every hospital. So if a person arrives in an emergency ward in a hospital where there is not this type of unit, telethrombolysis can help us save lives and have people gain 2 or 3 additional years of life. So let me take another precise example. It's the same system that can allow us not only to manage the shortage, but also to contribute to certain territories a healthcare offer that never existed there in the past. We're developing telemedicine in the highest Pyrenees valleys, and even here, there are high valleys in the Pyrenees, and I dare say that even here in Chamonix. So above Pau, in Laurent, in the valley of Aspe and the Sceaux, we are ensuring that telemedicine from a pluridisciplinary health center then provides services to this population that the population never had before. So that's a typical example that we need to apply in telemedicine. Well, for me, that's typically Parisian what happened. We decided that there would be 9 experimental territories, which would be digital territories. This was decided 3 years ago. This year, luckily, in the PLFSS, there is an article about telemedicine, and what do we see? There's just a generalization of the experiments. So I think this is ridiculous. This firing power of telemedicine in terms of doctor's visits and follow-up. There are experiments in Auvergne on cardiac heart failure that actually show how successful it is. And we still have these PLFSSs that just want to manage it in an experimental way. As we said earlier, as Xavier Bertrand said, how are we going to, in Aquitaine, for example, where are you going to find the funds? This is ridiculous. We have to change this law. Well, in terms of telemedicine, I would like to say, let's give some independence to Paris. Let's give Paris its independence back. There is a very strong separation between, on the one hand, what people expect in the field. When you hear Michel Lafourcade talking about these high valleys of the Pyrenees, we can bring healthcare offers where they never had specialized healthcare before, avoiding transporting patients. I do telethrombolysis as an on-call doctor, but it's a public duty to do so, but we're really behind in terms of innovation. But in terms of telemedicine, we realize that there's a high expectation from the professionals who don't understand why we can't make progress, why we're not really pushing for tele-expertise in telemedicine. And then there's a national message, which is to say, beware, is this not a Pandora's box that we're going to open that may explode in our face? No, I understand this national message of financial tension that's very high, and there is a budget to respect, but at the same time, it's a very anachronic message. This experiment in 5 regions with 2 pathologies, which was respiratory failure and heart failure, this represents an investment of 90,000 euros per year. Xavier Bertrand, I think you wanted to comment on that? Yes. In what Olivier just said, we always come back to the same thing. Paris is afraid. Why is Paris afraid? They're afraid of cost exploding. So people say, do these innovations, but above all, please do not exceed the objectives in financial terms of our state health insurance. But we're going to have to also look at reforming the prices, or maybe set up new tools to help innovation. But something sustainable that will give us a visibility for all of the actors. Well, I'd like to discuss the problem in a totally different way. Telemedicine requires a certain number of elements of equipment and infrastructures. Yes, so you have to be able to transfer the data. If you look today at all of the territories, not all of them are completely ready with the same type of balance for all of this. So what are we being asked let me take my hat as a local official. We're being asked to install the infrastructures. These are huge investments for the territories, especially in the most rural territories. And that's where it's the most essential. And they don't have the resources. So what do? Well, the state has very politely granted us a certain number of loan facilities. But let me tell you, in our local territory, even just our group of conurbations that I chair, we have 20 million euros for 5 years to have the infrastructures and to make sure that we then can offer telemedicine to our inhabitants, and so that practitioners can then use this system. And this is where I say that we have no long-term vision. And this is where I agree with what was just said by Olivier Véran and by Xavier Bertrand. We have, Paris is afraid, terribly afraid of investment. And people don't think in terms of investment at the state. People just think in terms of expenditures. An investment is not the same as an expenditure. So as long as people haven't understood the difference and they're not able to measure the impact of these investments and the return on investment with a medium and long-term vision, we'll remain in this situation where we say, yes, it's very important, we have to do it, but be careful because it's very expensive.
So I agree that Paris is afraid of the regions. They're not familiar with what we do. They know us very little. And if you go down from Paris into the regions, it's ideologically a bit disturbing, just going down. I don't know if I agree. I don't think Paris is completely disconnected from the regions. Don't confuse budgetary pressure, which is based in Paris, which is the guarantor of the budget of the state, and debt reduction, and what they would like to do. I think it's like in a hospital when you're a medical team and you're talking with your management team, you say, I really want to invest in this. If you buy me this machine, it's a bit expensive, but we'll be able to care for people in a much more effective way. We'll be able to do research. We'll be able to take market share. We'll bring patients in. And the management will say, yes, we want to do that too, but I have a hard time finding the investments. It's not because they don't want to do it. So I think we need to be clear about that. But also let's look at the room to maneuver that's left to the field. I talk about the building of one data center per GHT or several. But careful, those are expenditures that don't make economic sense for our country, and they could be centralized. I'd also like to talk about the information systems for the hospital, regional hospital groupings. If we consider that they'll cooperate together, I know that the project of the decentralized DMP didn't work very well, and I don't know what the national healthcare will come up with. I think they'll come up with a good project, but let's be careful about the multiplication of initiatives that won't necessarily be complementary, but rather redundant. So we've got 5 minutes left in our round table, and I'd like to ask the question about, can we have a vision of things that is much more regionalized, to have this autonomy of treatment of funds that are non-fungible between the state and the region. So, Michel, what's your position on that? This is a very political question in the noble sense of the term, so it's not part of my competencies. I would just say that as the managing director of an ARS, I think that I'll explain what I consider to be the real needs, and you see if it has to be translated or not into this imperative need. So since the law of 2009, we've been looking for more flexibility with this regional intervention fund. And I would need that. I observe that a lot of experiments were positive, that they've been assessed in that way by independent experts. I'd like to see them rolled out in my region. I'm not talking about the national level, but at least at my level. You voted for the digital regional territories. We are one of them in Aquitaine, and we're one of the 5 experimenting regions, and I can say that we really have the feeling that we're not doing cosmetics only. We need to work further. We need to work with more networks, more experimentation. And I'd like to be able to hear this throughout my region. When I need more flexibility in terms of fungibility with making what was positive in the experiment sustainable, you let me know if this has to be translated by what they're calling an hors d'âme or not. We'll let Xavier Bertrand conclude it after you've given your comments. When I was an MP, the question was asked, do we vote for an hors dam or not? I don't know if we're technically operational to go further in the discussions around this hors dam. We would have to have a more rigorous evaluation, and things could be very unequal as a result. If I take the example of psychiatry, between sectors we can go from 100 euros per year per inhabitant to 170. Does that reflect the inequalities in access to health care? Is it justified in terms of the population? I don't have any indicators that allow me to say that today. So let's be careful. If we start cutting the envelope, the global envelope, into territorial envelopes, we'll be able to work properly. Will we take into account the public health priorities, obesity one year, cancer the next? Will we have stop-and-go boutiques? I'm not sure about this. I think we have a good administration that's working well, and that is our national healthcare system. And I think that rather than moving to the hors dam, we should try to give more room to maneuver to our regional intervention funds to extend some programs and continue things when they're doing well. I think it was even said here, the hand health surgeon network, it's the centimeter of body that costs the most. It's these workers who cut their fingers off, who end up on workers' compensation. It's very expensive, and the people who have these types of pathologies, it's very hard on a personal level. So what they did was they worked on prevention in companies with explanations about how to work with the machines to not hurt yourself. And they're seeing a reduction in 30 to 40% in those companies after 3 years. The experimentation has taken place, and we need to finance other things. So we all have examples of this. So rather than going to what they call the hors dam, the regional objectives for health insurance expenditure, we need to look at the questions of a national agency that could be have a delocalized rollout in the regions. And I think this is something that we could talk about in the presidential campaign. Just one word, and then we're going to hand the floor over. So I don't want to go into the details of the hors dam. It's quite complex, and I don't know how we could regionalize or territorialize this. But I'd like to come back to the idea of the short term and long term. It seems to me this is what we're measuring in companies now. In companies, when we think about a business plan or a development plan, we look at the trends. We're not scrupulously looking at the expenditures or investments down to the last centimeter. We look at the types of trends we want to have for the company. And as it was said, we have a healthcare system that exists and that is not of poor quality, as opposed to what some people could say. However, I think it's very important that we have this long-term thought process about this. And the difficulty with this hors dam is that we decide budgets for 1 year, and we don't have this vision of the trends. We're not always taking into account the increase in demographics. If you look at the demographics, you think, okay, 1.5% growth, and the hors dam will have an increase in 1.25%. There's already a gap. So how can we continue to work when we know that in any case we'll have more needs than we're financing? So I think that's the direction that we need to look at. Xavier Bertrand, I'll hand the floor to you for the conclusion. I think we need a new type of governance for the hors dam. An hors dam means ensuring a fit. These are the discussions that I had more than 10 years ago with Pierre Méniory, who was the president of the commission. I was the Secretary of State for Medical Insurance, and then a minister. So how do we find this fit? I'm not sure that we're ready for that today. Between a well-established regional objectives for healthcare expenditure, I prefer the hors dam rather than looking at this only at a national level. I think we need to look at the real distribution. We have the state that's the guarantor that has to take into account the 3 waves of financing. So the question of aging, the question of more personalized treatment that is more expensive, and all of the digital questions. So for those three elements, we need the state to be guarantor, to have a strategy, but I think that the territories can play a role to decide how to implement this. There are questions, as was said earlier, the questions of new technologies. There's an ethical question that's a key question. We can't behave ethically differently in Paris, the Hauts-de-France, or the other regions. I'm not asking for less state. I'm asking for a state to revisit its role and to not forget that its main responsibility is to see what resources they're assigning to health. I don't want to preach that we're heading to disaster, but when you look at the moral of certain health actors, we're seeing that our system is having a problem because the health actors are the best barometer to measure the health of the system. The system is threatened because there's not enough responsibility taken by the main actors on this question of health. At the beginning of the year, we all say, I wish you a good year and good health. They know it's important, but in the political positions that are taken, it also always comes after identity or national identity and other balances. But if I wanted to participate in this debate, because I know that some actors want to be involved, they want to be heard by the national politicians who are responsible for these questions. Thank you.